So at the end, I will have distal LAD, but without septums. We don't like that, right? So what I did, as Imad showed, I did this, I stopped here because I know that if I use this way, I will lose many septals, which we don't want. I stopped that procedure, and you know, I have, after 1 month, I called the patient back, and now it is okay. It's not a CTO, I have a nice lumen, and it takes 10 minutes to fix this patient. And we had 1 year follow-up, which is perfectly open, diagonal and LAD. Another important issue, most of the time, sometimes we choose retrograde. My slides is okay. Okay, so you know, if we have dissection, if they have bifurcation at the distal, like we have here, this is 30 years old, very young chap. He has long CTO. I don't know why it happens, but it's long and complex CTO. It's very. We have very less chance if we try to open this antegrade to find the true lumen at the bifurcation, right? Because at the carina, we have 2 big branches. So in that case, we primarily can go retrograde if we have good collateral. We have good collateral here, and we did retrograde to save both branches. But it's not helping all the time. It's most of the time it helps us to save the side branches, but in here, as you see that, the side branch become very tiny, and then we lost it at the end. But it's big artery. I have to gain it again. How we do it? I did use IOS help again here. It shows me there is the osteo easily. And then I did in here, if you see here, I'm not sure if you see it here. Very dark, I don't know why it's so dark. Okay, so we did in here, we did started in here, with pilot 250. We just had the knuckle because I feel that my wire, pilot wire, got suboptimal space to bifurcation PLA, and then I just pushed it as a knuckle, and it's called Hill-Start, and I find the tournament. And I did the injection to see where is the tear, because I had to close that tear. And now we put a stent as clot patient here. And we did kissing. This is the result after clot technique. So we have 2 branches here. We have a small hematoma, you see that? But nothing happened. We just followed the patient. Another important issue, when we wire the distal bifurcation, we have to make sure our wire cross at the perfect position is the carina. Yeah, and the carina has to be in that wire. Otherwise, we lose one of the branches. So in this case, for example, we have a good bifurcation at the distal. You know, this is Corsair and Miracle 6. Miracle 6 cross the lesion to diagonal. So the question is, if I use this wire with balloons, if I could lose a lady, right? That's the first question we have to answer. What we did here, I always do this. I push my bifurcation, I do tip injection. Normally we don't do tip injection, right? No need. But here, I'm thinking if I do tip injection, if my contrast goes back and goes to LAD, it means that there is no flip between this diagonal and LAD. So this shows me I punctured at the right side, and if I use this diagonal, I will not lose my LAD. So, and then we did ballooning. I direct my wire to LAD, and this is the final result. So this provisional technique. And this is another important case to me. LAD occlusion is long occlusion. I don't think there is a CABG option here. So we tried to first open this artery antegradely, but we failed. So then we have nice collateral from as you see here, this is very nice to use. You know, the scepter is extremely nice to use for retrograde approach. So when we try, you know, 5 to 10 minutes, we failed, and we just went through this septal, and Sion wire can easily cross in 1 minute. And then after that, we try to do, cross this lesion to the proximal lumen, but we are in subintimate the proximal part. This is very important. Again, you might have a flap between this big diagonal and my wire. We don't work it. I tried some. I did, I tried, but I couldn't make sure that, I'm in the right lumen here. Still, we have some distance between wire and lumen. So in that case, I thought it's better to do reverse cut. Means I sent a wire from a proximal to the distal, and then I did some dilatation here, distal to the diagonal. In that case, we call it reverse cut. In that case, my wire went to the space done by this balloon, and this balloon space connected with the true lumen. So it shows me that I will save this diagonal. We can use here diagonal as well if we need it from antigrade. Anyway, in here, this is the situation. We did mini crush. As I told you, we don't have any other option here. We did mini crush with 2 DES, and then we implanted 2 absorb here because of the distal occlusion of the LAD. This is the final result. This is my last case. This is also important to mention. Sometimes, you have epicardial collateral, and that collateral supplies artery, supplies the CTO. We couldn't open this antegrately. We used that ventricular collateral, epicardial collateral. It comes from the retrograde epicardially, but the main artery goes like that, right? This is only side branch. We did Rosca. And then we did look here, which is okay. But after that, this is the RCA is here, and I have some dissection now. I have to take care of this RCA, otherwise I will lose flow of the RCA. If this, maybe gives me inferior MI. So I have to take care of that main artery. To do that, I have used double lumen catheter again, and with part of 50, sorry, I did another knuckle. You see, now I have a knuckle, and I pushed it. When I pushed it, it goes lumen. First side branch, subintimal side branch, and now I'll have a knuckle, and I use as advantage. I first push it to do static, and I have to make sure, of course, where am I, and shows me that my pile of 50 is through lumen, and I did stenting. And after the stent, we have a nice. So those are my slides to talk about clarification, CTO, and I'd like to invite you to our meeting in Istanbul, a cheap meeting which is complex PCI. We focus on complex PCI and also high-risk patients. 39 and 10 September. And I'm very happy to have you. And also we have, for CTO guys, we have CTO Essentials meeting. This is a big meeting in Europe. We have more than 300 attendees every year. And also I'd like to invite you here, which is end of October. Thank you very much for your attention.
Thank you, Dr. Omar. The next speaker